It's my great pleasure to introduce this panel. But what I'm going to do is I'm going to read these very, very long, detailed bios of everyone, because everyone has so many talents. And that gives you time to think about the question. Because I thought we've got 2 million questions that the team at Women's Health Victoria drew up. Only 2 million. I thought, why not 3 million? But they said, no, 2 million. So I thought what I'd do is I'd just start with something broader and maybe get you to sort of think about what's exciting you at the moment, because I think it's good to talk about excitement. And this morning, Nancy and I, we were talking about pleasure, actually. How many of you talked about pleasure this morning? Or maybe you had some pleasure. Yes? No one's admitting anything. But we were just talking about pleasure and harm reduction, weren't we, Nancy? So, but I thought, let's just go wild. Let's forget about the harm reduction just for a moment. And while I'm introducing you, you can think about what's making you really excited in this space at the moment. Is that quite a good question? And then I can get into some nitty-gritty ones if the conversation dries up, which I'm thinking it's not going to. Am I right? Not with these dynamos here. Frankie Freeman is the Community Liaison Manager for the Victorian Mental Illness Awareness Council, also known as VMIAC, the peak body for those with lived experience of mental health in Victoria. She's particularly passionate about assuming that lived experience is embedded in the development of policy and programs that affect consumers' lives and that their human rights are upheld. Thank you, Frankie. Can we give Frankie a big hand? And I just want to acknowledge lived experience, because I think there's a vulnerability about talking about things when they're about living. Hey. So, next. This is in no particular order, by the way. Professor Jayashri Kulkarni commenced her appointment as Professor of Psychiatry at the Alfred and Monash University in 2002. She directs a large psychiatric group, the Monash Alfred Psychiatry Research Centre, MPRAC, I probably said that wrong, a large multi-site clinical research centre with an extensive collaborative network nationally and internationally. The centre is dedicated to discovering new treatments, new understandings and new services for people with a range of mental illnesses. Professor Kulkarni has pioneered the novel use of estrogen as a treatment for schizophrenia and is internationally acknowledged as a leader in the field of reproductive hormones and their impact on mental health. An expert in women's mental health, Professor Kulkarni was elected the President of the International Association of Women's Mental Health, a role she held from 2017 to 2019. She sits on many advisory boards for government, the NHMRC, can you give me a grant, industry and universities. Did you notice that? Professor Kulkarni is a popular speaker with numerous media engagements and was recognised for her contribution to medicine, particularly psychiatry, by being made a member of the Order of Australia, an AM, in June 2019. Can we give Professor a big clap? Professor Jane Fisher with the fabulous glasses. Oh, like they could make me turn. Really, to glass wearing, is Director of Global and Women's Health and Head of the Division of Social Sciences and Public Health and Preventative Medicine at Monash University. She is an academic, clinical and health psychologist with long-standing interests in the social determinants of health and healthcare participation. Her research has focused on gender-based risks to mental health and psychological functioning from adolescence to midlife. Now, Nancy needs no introduction, do you? But I will say this one thing. Go and check out his zips in the morning tea break. Okay? Because they're very cool. Very cool. Last but not least, Jackson. We're saving you. Jackson Fairchild is a Senior Policy and Strategy Advisor, Rainbow Health Victoria. Next time we see Jackson, they're going to have rainbow hair, are they not? Jackson has over 10 years' experience working as a clinician, educator, supervisor and service leader across family violence, suicide prevention, trauma recovery and LGBTIQ health. A qualified counsellor and clinical supervisor with a lived experience of family violence, Jackson's recent roles include Director of Practice and Learning at No to Violence and Manager of Counselling, AOD and Family Violence Services at Thorn Harbour Health. So awesome. Thank you so much. Big hand. Do we have any woos in the audience? Hey, awesome. Very good. Have you been practicing, Misha? So we're at a critical juncture. I'm warming you up now, warming you up for the conversation. We've had a Royal Commission into family violence and are in the middle of a Royal Commission into mental health. We've just had gender equality legislation introduced into the Victorian Parliament. And, you know, how do we make the most of all these opportunities to improve women's mental health? So what we've got is we're going to have 45 minutes of discussion, then about 15 minutes of Q&A with the Slido. So if you haven't already jumped on there, add your questions, vote, like questions. So what I'd like to do is start by really getting your thoughts. And Jackson, you've got the mic, and Frankie, you've also got the mic near you and haven't spoken yet. So I wonder if I could ask you two to start us off if you're feeling warmed up sufficiently. And Jackson, you might want to start and then we go to Frankie. But just your thoughts about what's exciting about these developments and what the potential is. But really anything about pleasure would be good.
Rainbow Health Victoria, can you hear me? Is that clear enough? Rainbow Health Victoria is part of a sex research institute, so we talk about pleasure all the time at work, which is pretty fantastic, yeah. What am I excited about? I was quite heavily involved in the Family Violence Royal Commission, and I've been quite involved with the Mental Health Royal Commission submission work around the LGBTIQ community. I'm very excited about that, but what I'm most excited about at the moment has been, I've had the pleasure in the last year, see I wove it in, pleasure.
So good.
Of travelling around doing a lot of training as part of my job as well, helping transform the family violence sector into a more inclusive and safe place for LGBTIQ people to travel through and receive support from. And what I'm so excited about is we often hear about the backlash. I spend a lot of time talking about men's rights activists. I spend a lot of time talking about sort of that backlash to violence and, you know, how sometimes it feels like we're going backwards. But actually what I'm really excited about at the moment is the level of support and conversation from allies in the community at the moment, that I go out into so many spaces and I meet so many amazing people who, when we walk in the room, say, we're here, we're not queer, but we're really wanting to help. And we recognise there's a lot of challenges, and they've really got their shoulder to the grindstone on transforming their services, not just family violence services, but all services, including mental health and women's services. And the amount of particularly women who are not part of the LGBTIQ community, who have come forward and just been some of the most incredible allies and visionaries in this space to create the pathways that we so desperately need in our community with the rather concerning rates of mental health that we have. I'm very excited about this Royal Commission because I believe that we just have this whole army of people in the community who are really standing by and ready to step up.
Not sure whether... Is that working? Okay. I guess one of the things that excites me most at the moment is just how much I can see lived experience starting to get a little bit of traction in terms of being recognised as a valid form of evidence to change the policy and the programs that we currently have. With the recent announcement of the interim report for the Victorian Royal Commission into Mental Health, I guess I was really heartened by the fact that that lived experience was, you know, right through all of those interim recommendations, not just in the specific ones to do with the creation of lived experience jobs and lived experience residential service. So that's something that's really, really exciting, particularly coming from a position where for quite a long time, working from a lived experience perspective, often sitting in a room with many other people who were telling me that my experience wasn't valid and that I was wrong, and that what I had experienced still wasn't enough to kind of change their, their clinical procedures or how they do things. So to kind of move in that direction, it's something that I can see it is going to benefit the whole community, because the purpose of our organisation, VMIAC, is really to recognise that the people who have walked the walk kind of now are needing to do the talking as well. So from my perspective, and how that relates to, I guess, women and girls, is, we often get, when people call us up, they're not normally calling us up because they're having a good time in the mental health system, and that's just a part of the work we do. So they're normally calling us up when things aren't going right, and we do have, unfortunately, disproportionate representation of those voices that we get on the end of the phone are women, and a lot of that is to do with how the systems are set up to support women. And I think, all the reforms that we can look forward to coming in the future, obviously I do hope that the final report does have that idea of, that kind of more, I guess, gender transformative practice embedded into it. But what I can see at the moment is that we're starting from somewhere which is probably not where we were probably 20 years ago. Yeah.
Well, what is really exciting me is there seems to be more of an appetite for prevention. And that's not to reduce the incredible importance of providing sophisticated, comprehensive, sensitive care for people who currently have mental health problems. But I think we get further by trying to reduce population prevalence. And what is exciting me is that more of the conversation in this area is about the need for gender-informed approaches, and therefore the need really to ensure that all these efforts counter harmful stereotypes to which women in particular are subjected, that they skill health workers to be inclusive of men and boys in the ways we were hearing about this morning, but not to condone harmful stereotypes in these interactions. We have a program of this kind that is seeking to prevent mental health problems at a community level, with community nurses facilitating this, and I'm very pleased that the Department of Health and Human Services is now rolling this out at scale across the state. That's been a 20-year effort to persuade them that that's a worthwhile investment of their resources. So to me, it's very important that we think where in the intergenerational cycle we can intervene effectively. And there's not just one point, but it is very effective to intervene at the point where people are caring for young children and are themselves pregnant or having children, because I think every parent seeks to do the best for their child. But if their own experiences in early life have been harmful or diminishing, they don't bring a confident working model to that work. But it is a time when it can be very constructive to assist people to do it better, to make changes. So I'm excited about psychoeducational approaches made available to everyone because they're less stigmatising, that have the potential to address at least some of the intermediary social determinants of mental health problems, while we continue with our incredibly important efforts to make changes at structural levels with policies of the kind that others in this group are very expert about.
Thank you. I'm going to say something controversial. I'm not excited, and in fact, I'm actually at the point of nearly giving up, except for this group. So thank you, Diane, for inviting me today. I feel refuelled by being here and by hearing what Lorraine and Nancy had to say. Let me explain why. I'm normally an incredibly resilient and optimistic person, but I have worked in the mental health system for, since 1981. And I have been a director of a mental health service, and I've worked as a consultant in the mental health service, and I still am attached to a mental health service. And I was really, really, really hoping that by now we would have destroyed the mental health system and built a new one and built it really, really better and different. And I look at the interim report and I struggled hard to find women's mental health in there. I'm really concerned about some of the things that I've worked very hard on with the Mental Health Complaints Commissioner, for example. She commissioned me and my group to go around Victoria and have a look at the complaints about sexual abuse against women in the mental health wards, right? And what I saw was disgraceful. What I know is disgraceful. What people in the system know is disgraceful. And the Commissioner's report was a beautifully put together, politically savvy report, which has got what was in there, about 2 paragraphs related to that, but no action plan. Nowhere does it say, you know, there's 170 new beds for youth and adults, but nowhere does it say we're going to protect women who need to go into the mental health system. And there's a simple solution that you could protect the women who need to go into hospital, because it's still happening today. So I'm sorry, but, you know, these things, I think, you know, decades have gone by, and I would love to see. Now, maybe I'm impatient, and maybe the next iteration of the report, and particularly with the work that's going on from the Women's Alliance, which Women's Health Victoria have put together, and maybe this is another, you know, opportunity that's a good opportunity to get there, to say, okay, you know, what are you doing for women? Perinatal services are pathetic. You know, the number of mother and baby beds that we have are appalling, and it's just disgraceful. Because if you think about, as Jane has, you know, worked in as well, if you let the ball drop in that early time, you've not only stuffed up her, the mum, but you've stuffed up the next generation as well. So why are we not saying that's really where we could be preventative? So you can hear the frustration, the anger, but I am heartened by an integrated approach, and that's what you, Lorraine, and Nancy did, is you talked about what I've been banging the drum about. It's got to be holistic. You can't ignore neurobiology. You can't ignore the body, as well as in conjunction with the brain, the mind, and the social context. And we've done that badly, I think, as well. For example, how many psychiatrists are there in the room? You know, and that, I think, is one of our issues. You know, what are we doing that there's a whole bunch of people that are labouring long and hard without having the benefit of education, support, and all of the stuff that's needed to be able to bring the standard up? Because there's some simple things that can be done right now that are not being done. So I get excited about the potential, but I'm frustrated that we're not there yet. Thank you.
Well, I'm really glad you said that, because I feel like I'm excited for the moment that you're at. And I just want to mention where we've come to in Canada to hopefully give you a bit more oomph in the struggle that you're facing right now. In 2006, the Senate Social Affairs Committee in Canada published the first ever national report on mental health in Canada, which is shocking in itself that it took till that long, but and it was called Out of the Shadows at Last, right? And one of its key recommendations was that they create the Mental Health Commission of Canada, and that was great. And the first thing that the Mental Health Commission of Canada did was it held consultations across the country, and Lorraine and I presented into the consultation that was held in Vancouver, and I pulled that up this morning, Lorraine. I don't think I'd change a word. Anyway, what we pointed out was that Out of the Shadows at Last was completely gender blind, and that we recommended they use SGBA plus in their work going forth. And particularly we noted how stigma was gendered, and how, you know, if you were going to focus on stigma, that you really needed to take into account how that played out. Well, absolutely. We were publicly rebuffed by the head of that commission at that time, who said it was no accident, it was gender blind, and, you know, see you later. So we saw the Mental Health Commission work on very well in many ways, but in a completely gender blind way over the last few years. And now that, as Lorraine mentioned this morning, we have this kind of stick approach that, you know, you now must deal with sex and gender-based analysis in your work, and the Mental Health Commission of Canada has now invited us, Lorraine and I, to work with them around thinking through how they might become, to bring sex and gender-based analysis into their work. And we recently had a great workshop with some of their staff around particularly the mental health needs of women in correctional facilities and the mental health needs of caregivers. So it was very interesting to see that there, you know, in some ways, I guess I feel excited and heartened by the fact that the stick approach, when it comes out of due necessity, has actually not been one where people have their brakes on still, but is a time when I feel like people are genuinely interested at the Mental Health Commission of Canada about doing this. And I think that that could be very much what's happening here. And I just want to give a shout out to VicHealth about the booklet on resistance, because I think it's a great moment to think through where the resistances are to having gender and sex incorporated in the next steps of the mental health work here. And I think there's some great guidance in that publication around moving forth, around in very positive, appreciative ways of getting to action in a way that people have passion for, have excitement for, instead of not, you know, coming with the brakes on. So I'm really happy that you have this moment, and I think it's going to be a great one.
I've got about, I think we could have a panel for about 3 hours with these fabulous speakers, but I'm kind of wondering about what you think might be, and Jayashri, you've already touched on this, some easy things that could be done. But what are some gaps? Who's missing from the conversation? How might we be able to address that? What are some things we can put in place in the future? I guess I was thinking as you were talking about who's not there, who is there, who's missing, where are the holes in our vision, who are we missing out on ensuring receives the healthcare they deserve. And, you know, Jane, your emphasis on psychoeducation to sort of reach as many people as possible was really exciting, while also making sure we address the structural, because we need all of the strategies. So I'm just sort of wondering whether you could all perhaps say a few words about strategies or tactics. What can people do here that are in the room? And who's missing, or who should be there, who's not getting a voice? Are we, you know, which group are we not serving, or which groups? And perhaps Jackson, you might want to start.
Is that on? Yep. The first thing I think I just want to acknowledge the conversation around prevention is really important. It was something that in our research now, just conversations around the sort of LGBTIQ community, we talk about the drivers. Why is it that members of our community are experiencing such alarmingly high levels of suicide, self-harm and mental health? And we're developing a clearer vision of the drivers within society around transphobia, biphobia and homophobia, which just have such clear links to us with misogyny and other forms of rigid gender norms. And I feel like when I hear about these drivers, and when you talked about, when we heard earlier about the different disciplines not talking to each other, I also feel like, and this isn't a low-hanging fruit, this is a big one, but I have a low-hanging fruit to offer in a second, which is that we talk so much in the family violence space around what those drivers are doing, and we heard earlier on about the work around masculinities, and we talk about mental health as though these are somehow separate conversations, and I feel like there's just so much that could be learnt in between in terms of this research, the incredible work that Our Watch has done to create a united vision for Australia to talk about this issue, but the links between violence, trauma, mental health, and these drivers, these attitudes in society that are holding us back. How can we stand arm in arm, in lockstep, to create a safer, kinder, more welcoming world where kids are born in and are given the best possible chance they can? I think we have the tools, I think we know, but I don't think we've brought everyone along with us yet. I suppose what I'm saying is I think we know a lot that we're not putting into place right now in terms of these social drivers. I can't speak from the biological point of view. I know that in our community, we know what needs to change to make our community safer, and that's just not happening. In fact, we're kind of going backwards at the moment, unfortunately, and we don't have the full support of the community to do that. And I think that a lot of that work around how we promote and hold those conversations, how we bring the community with us, is happening in the family violence space, and it needs to come over to the mental health space. In terms of an easy thing that we could be doing right now, I feel like just building conversations and spaces for those conversations and trying to create, coming from the point of view of a part of the community where the idea of having a conversation around with someone like yourself around approaches around psychiatry where those disciplines feel so different. I just think it'd be so wonderful if we could all if we could have these community of practice spaces where we could have a more robust dialogue and for us to be sharing our different points of view and agreeing to disagree and throwing things around. I just don't think the spaces exist for that to happen.
Totally. I mean, I think one of the things that happens is, there's a moral imperative to fix up the social context. That's what we're talking about, that we should all be much more accepting of each other and diversity and behave nicely to each other, and that will help a lot. But how do you get that into a clinical practice in a struggling service? And let me tell you, the trauma-informed care has been a catchphrase, but that's it. It's just a catchphrase. I did a study 2 years ago, or one of my honours students did a study where we looked at 200 files of people who had been admitted to a service to see what trauma was identified for each individual. And in 56% of those individuals, nothing was even discussed. And this is despite everybody running around going, trauma-informed care, trauma-informed care. So we lose stuff in translation. We've got some great brains, but there's almost this kind of huge fragmentation. And by the time it gets to the floor, or the ward floor, it's gone. And we're back to, awful things. And I don't know how, but that's why I say there is a group missing, and that's the clinical practitioners who are the front end of our mental health services, and the primary care practitioners, the GPs, who are also the ones who, what are you going to do with this person with chronic severe mental illness? Well, the GP will manage them. How the hell is the GP going to manage them? They've got nothing except 7-minute consultations. So that's, I think, two groups missing.
For a second to answer that. I did a study in one of the psychiatric hospitals in Canada where we asked people at intake when you get upset, how would you like us to respond? Would you rather be in a room by yourself, or would you rather stay out in the community with others, or blah, blah, blah? So it wasn't trying to case find for trauma. It was trying to case find for how we should respond at the time of entry. Anyway, it was just a really interesting study, of course, when they were asked, because not all the clinicians did ask in the study who were supposed to, and when the clinicians actually did what the person said was their preference, those folks had a much better outcome in the context of their experience in an institution. And so I think it's just a real thing for me that one of the things that's missing is this focus on wellness and strengths and resilience, instead of focusing on the diagnosis, the problem, and the trauma as we do this work. And, you know, I've certainly learned a lot from Indigenous women in Canada about a wellness and resilience-oriented framework that they're so good at. And so I just think that is one of the ways forward. And those voices of Indigenous women are one of the groups that should be at the forefront. Do you want to?
Yeah, I think from the original question, I've kind of gone around a few times to kind of respond to all these individually, but it really comes down for me, and I guess I'm beating the drum here because it's the organisation I work at and it's my life, but it really comes down to lived experience. And it can't just be embedded in terms of, you know, you ask someone something once at a certain level, it's where it goes up to. So the Victorian Government worked on a thing called the Lived Experience Engagement Framework, which I was really fortunate enough to be a part of. But what happens in practice, how it works is it says, okay, to do lived experience really well, you need to do this, this, this. And this is coming from people with lived experience. This is what you need. And then you hold this piece of paper up when you're working for DHHS and you sit there and go, yeah, this is what we need. We'll go in, we'll consult here, we'll do this here, this is co-design. But in practice, what happens is, well, we don't have time for that. Oh, the minister's putting pressure on me to do this. Oh, no, well, we've only got 6 months. When clearly outlined in that document, it says you need to allow for the time. You need to allow for the time and the expertise coming from the people with the lived experience, because if you don't, what you're going to create is a Band-Aid to try and fix a broken leg. I'll give you a really great example. It's a terrible example, really, but a great example of how bad when you don't do it right gets. Working in a higher up type consultation process. It had a big wanky long name with lots of acronyms. And they asked us, they said, oh, we've got this place-based suicide prevention program coming up. We've done this, this, this. We're about to advertise. What do you think we should do? And I said, wait a minute, you're about to advertise? And I was like, have you had anyone with lived experience involved in developing this? Oh, no, well, we kind of, not really. And then I said, well, when you're advertising, who are you advertising for? Are you going to make the position lived experience identified? Because if you're doing it in a place-based way, you're probably going to want to get that feedback, because it's going to be in those communities that matter, like how you put those intervention in. It's going to make more sense to, you know, take that experience from someone who's been there. No, we haven't really, but that's up to the services if they want to do that, which comes back to this idea about the carrot and the stick. We don't have the stick at the moment, and this is what I've said to the department is we need the stick. So whenever we do any of these consultations, we get KPMG in or Ernst & Young or whoever it is, none of them have lived experience identified positions, and they should, and it should be a part. If they're putting a tender into the government to try and create policy and develop programs, that organisation that puts in that tender needs to show that they understand the lived experience perspective, and without lived experience positions, they can't do that. So that's a long way for me to answer of who's missing, but I think that's where it comes down to is if we don't have that voice there from the start, we're going to continually have the feedback from the communities that are affected by it, from the people who have to live this every single day and say, hey, you haven't got it right. And then we're just going to have to start over again, which is so frustrating, which I completely get your comments earlier on. Yeah. Sorry, that was a bit of a rant.
No, I've said I think these are just outstanding contributions. They are all incredibly important ways of allowing us to organise our thinking in this complicated area. But I do think it would be a pity if prevention efforts were positioned as competing with efforts to improve the quality of care, which I completely agree with Jayashri and others is appalling. There has to be endeavour to improve that. But if we take a longer term view, which does mean going beyond an electoral cycle, I think we really do have to invest a lot in seeking to reduce adverse childhood experiences so that children enter their childhood years, their adolescent years, their young adulthood positioned better to be able to adapt and manage the inevitable adversity that they will experience in life. And at the moment, the efforts in that area are predominantly within research. I haven't heard enough yet that's happening in a programmatic way. There is research which is seeking to do this. And I think the second part of this is that I have found in my dealings with government that the numbers really speak to them. But trying to build evidence of a quantifiable kind that says doing it this way is much better than doing it the way you're currently doing it is really difficult. And as Jayashri and I both know, securing research funds to run a demonstration project that says running this kind of service is better than that is a very difficult thing to do. But when it has been done, it's been a very powerful way of bringing about change. So I do think one of the groups I would like to see actively involved here is people with research capacity, research evidence building interests in this field. And it's not straightforward, and there isn't a single form of evidence that should be positioned as superior to others, but without it, I think our efforts are still seen as being emotionally charged, not rational, all those things that minimise them. And I do think that collaboratively there's a lot that researchers and advocates can do together.
Did you want to add anything, Jayashri, before we go to the next question?
Yeah, I mean, I totally agree with a lot of the comments, but the problem is that when we get down to it, it's the resourcing issue. And the pie is very small. And so it becomes the loudest voices that government listen to, the same voice pretty much in the mental health field, and the politicians who pick off the easy ask. And that's often something that's not to do with severe mental illness, because that's the too hard basket. So again, I just think that we need to do all of the above. We need to do all the preventative work. We need to have a biopsychosocial framework that captures all the different capacities for research and treatments and service provision. Because as long as we are fragmented, it's too easy for people to not give us something meaningful because they'll just go, well, you can't even get your act together. So that's one of the big things that Nancy and Lorraine gave me this morning is the will to keep fighting, but also that underlining, holistic, everybody in this together approach. And we have not had that. We still don't really have that. And like you said, Jackson, it is about, you know, when do your tribe and my tribe get together? You know, we just don't. And we're still tribal.
Well, so much to talk about. Hey, and I just feel like we're warming up. What I'd like to do is move to the questions from the audience. And I think rather than get every single person to answer every single one, if you can signal with excitement and pleasure which one grabs you, and then we can throw the mic your way. Is that a good idea? Yeah. But, and it feels hard because I used to be a group therapist, so I keep wanting to say, I really want to kind of acknowledge what every single person says, and it's been really hard for me to sort of sit on my hands so that everyone gets a word in. But what I thought I'd do is just go to the top-rated questions. And the first one's around about politics, so that was a nice segue, Jayashri. When you've got Scott Morrison describing inclusive toilet signs in his department as over the top, how do we encourage societal change when leadership has publicly denounced it? Anyone want to have a go at that one?
Quite desperately.
That was not very convincing.
I wish I got $1 for every time I had to talk about bathroom signs, but I don't, so we won't spend too much time on that particular thing. I will actually answer the question, but I think it's about we need to resensitise ourselves collectively to what we're trying to accomplish here. It's very easy to be jaded at the moment and to sort of go a bit numb and switch off and feel like there's no hope. I look around the world, I look at some of the backlash and I look at some of the backwards movements we've had in our movement, but also more broadly around gender and the backlash to the men's rights movement and the alt-right and all of those things. And I think it's very easy to become oversaturated and to lose our optimism, but we need to be, like, this work is political, and I think we need to be standing arm in arm, and we need the policy stuff. We talk about it as this, we make submissions, we have meetings, we have these dry submissions, we write evidence-based things, but we need to be meeting, we need to be talking strategy, we need to be reaching across disciplines and going, what is it that you need, what is it that I need, can we advocate together? And we need to be mobilising collectively across our disciplines and working together to make it really clear to those in power that this is what's going to happen, whether they're on board or not.
So my favorite strategist is a woman named Flo Kennedy from the US, a black woman from the US who in a film I saw at one time about, said, how do we end patriarchy? And she said, imagine patriarchy as this lion that's coming in the door at you. And if you use one strategy, like the taser, that will temporarily dismantle it or appear that you're making some progress, but ultimately isn't a long-term or effective solution. And that she recommended the 10,000 mice approach. And that, to me, I think makes a lot of sense, where you just scatter 10,000 different strategies, some of them collective, hopefully, but even if not, just as many possible ways that you can interfere with the progress of the lion, then that is a good strategy. So that's my contribution to what the next steps need to be, 10,000 of them.
Look, I think that's a wonderful suggestion. One of the problems I think we have in understanding mental health problems is that it's not a single entity. It's not like saying someone has diabetes or they don't have diabetes, and these have been it's been much more straightforward to mobilise resources for these binary conditions. What we're talking about is complex human experience, social suffering, severely disabling experiences. But I think the term mental health is now used when really what we're talking about is mental health problems. And I think what comes to mind when we use that term is the 10,000 mice. So what Prime Minister Morrison has in mind and what Minister Hunt has in mind and what our colleagues have in mind, I think are very different things. And I think we would advance if we could get a more distinct descriptor that people can recognise, and we can acknowledge that these are spectra, they're not distinct binary conditions, and therefore that different people in the population have different needs in order for them to be able to function at their best. So we're not seeking the kind of intensive resources that are needed for someone with severe schizophrenia for 40% of the population. We're seeking that for the proportion that have those severe and highly disabling conditions. But for others, it might be self-management, it might be an evidence-informed e-mental health program. And I don't think we are yet telling that quite complex story in a simple enough way for others to comprehend.
This just happens to segue beautifully into my next question, actually. So this is from Slido, and the question's around about what do we need to change about education? And that's throughout the lifespan. What needs to be different? Who wants to?
I claim that I'm an educational. That's more your.
Look, one of the things that really perturbs me as an example of this is it's presumed that women will know intuitively how to care well for a baby. Most of us do not know how to do that. We have a better chance if we had the great blessing of experiencing sensitive care ourselves. But to me, it's such an obvious, and it's easy to demonstrate. If you show someone how to do it better, then that's usually an opportunity they'll take up. I think we can do this in many ways. Not expect people to discover for themselves how to do it, but say this is a better way than this, and here's how you do it, and I'll give you lots of practice to do it better. And we do this in the mother-baby unit I work in every day. We show people how to care better for a baby than they were cared for themselves. But I think we can bring this model right through. Here's a better way to relate to somebody. Perimenopause, even post-menopause. But I think we can really assist people to relate more respectfully to each other, with more sensitivity. It won't always work, but expecting them to kind of discover it for themselves, I don't think is a very useful public health strategy.
I'm wondering if I can go to another pressing question, because I'm doing a lot of triage here, folks. Any health professionals in the room? Thank you. And maybe I think this is a really good one to end on, and then we're going to give you a chance to talk. What change would you like to see in women's-only services to best support the trans and gender diverse community?
Yeah.
We've got 5 hours.
Yeah. It's a big question, and in the family violence sector, I run a 6.5 hour training session on that to get us to a common understanding around that. Yes, absolutely. Rainbow Health Victoria, we're happy to talk to you about any of your training needs. Obviously, my boss would be very happy for me to say that here. But the first thing I think we need to understand is when we're talking about this beast of patriarchy, and we talk about the 10,000 mice, and we talk about what we're trying to accomplish as a women's service, is that we need to work collectively to dismantle patriarchy. And I can tell you that there are some tools in the LGBTIQ community that are absolutely vital if we're going to get that done. And the lines that we draw around what we call a woman and how we classify women in self are built on patriarchal roots and colonialist roots that make a lot of assumptions that come from a place of whiteness and a place of rigidity that are themselves harmful to us. And by reinforcing that, I think... I've been practicing this a lot lately, so thanks to whoever put this question forward. And can I just say I'm really grateful that I'm getting the opportunity to talk about this in this space. It feels a bit emotional for me as I talk about it. As a gender diverse person, non-binary person myself.
You're surrounded by caring health professionals.
Yes, I am, and I really feel it. It's quite amazing, and I just wanted to speak to that. But I wanted to say, when we talk about masculinity, when we talk about femininity, where we put traits in different buckets, we're setting a line, we're sending a message, and I think we need to have lots of really critical conversations around that. But we need to be thinking about how we can work together, and I can't give an obvious, clear answer as to which service should do what. It's not my place to do that. I really respect the feminist history of different organisations that are doing their work and have said we are a women's only service for very important reasons. I absolutely get that. All I'm asking for, I can't answer those questions right now, is get organisations like ours or others out to have the conversation with you about your assumptions, about the research, and about how we might work together in that service space, because I can tell you it will transform your practice for everyone, including cisgender heterosexual women.
We've got Jayashri and Nancy, and then we need to wrap up. Sorry.
It's okay. I just wanted to, and it'd be really good to have Jackson's view on this, but in this whole scenario of assaults on women in the inpatient units, one of the things that was set up, and I was banging on the drum in 2010, and we did get money to put up women's only wing, not a whole ward, but just a wing, which had a locked door at the end, which each woman had a key to be able to access. But it was an area where the woman felt safe because her bedroom was inside this wing. Now, that has deteriorated with really bizarre things like the lock's been broken for 6 months and we can't get an engineer to fix it. Just stupid things, right? But then the whole process of can we build more of these wings was knocked back on the grounds that what are you doing with trans or other individuals? Now, I said stupidly, simplistically, why don't we ask the trans or gender individual where they would feel comfortable? And everyone just went, no, we can't possibly do that. And the whole program got knocked back.
Yeah. And that was what I was going to say, was that I really think we need to be asking trans women about this. And Lorraine and I have been reading lately about some trans women from the UK who have been advocating for the creation of third spaces. And I think that's one of the options that we should be listening to and engaging with in the discussions that you mentioned. But really, you know, lots to hear and listen for, I think, in this territory.
Is that too stupidly simple?
I think it's amazing. I think that's exactly what we always advocate. Have you thought about asking the client what they prefer? We released a guide. Yeah, just ask the person. And if you need to take your team and on a culture change journey, then figure out how you're going to do that. It's not as hard as it looks, and there's all sorts of options there, but that's definitely what we would recommend, is allow the client to lead their own care and guide their own safety, and there's absolutely no evidence that trans women are of any threat to cisgender women, so.
Oh my gosh, we could have had this panel all day, could we not? It's my pleasure to just really warmly thank our amazing panel for the conversation, and also perhaps some inspiration for us all to try and find and create spaces where we can have these conversations, yeah? Can we give them a big hand, please?